Anti-cytokine therapy in the treatment of psoriasis. So what is psoriasis? Well, psoriasis vulgaris is a painful and itchy skin disease that affects around 3% of the world's population. It can occur to anyone at any age and is known for the thick, scaly patches present on the skin that can last an individual their entire life once symptoms begin to develop. Around 20 to 30% of patients that acquire psoriasis tend to develop arthritis or stiff joints due to the inflammation around the joint caused by the disease.
The symptoms of psoriasis are caused by both innate and acquired immunity cells that are being overproduced, such as interleukin-6, TNF-alpha, and chemokines that cause inflammation. Skin cells, known as keratinocytes, produce those types of cytokines. Dendritic cells secrete interleukin-6, which initiates Th17 responses and blocks regulatory T cell functions. When Th17 cells travel to the inflamed tissue, it causes chronic inflammation and tissue damage, neutrophil maturation, and chemotaxis, Th1 cell chemotaxis, and keratinocyte proliferation and epidermal hyperplasia, meaning that the skin becomes enlarged due to the high production rate of cells. Interleukin-23 activates Th17 cells, thickens up the skin, changes regulatory T cells into interleukin-17 producing cells, and stimulates dendritic cells to present cell peptides.
The future treatment of psoriasis disease. No one has found a cure for psoriasis. However, there are several drugs that have been invented and are currently on clinical trials. According to Food and Drug Association, the two possible vaccines for psoriasis are one L17A inhibitor and one L23 inhibitor. Earlier this year, FDA approved one L17A inhibitor for clinical trial for over 2,400 patients. The one L17A inhibitor is a new helper T cell to recognize the antigen for psoriasis. It helps the innate cells to protect the skin from inflammation. As a result, more than 80% of the patient reduced the symptoms of psoriasis. By contrast, the patient developed side effects such as yeast infection, colds, and respiratory tract infection, while on the other hand, one L23 inhibitor is a biological drug that is used to create and develop protein. It helped to reduce the early symptoms of psoriasis. The L123 inhibitor has an important role in extra-immunogenic defense in the pathogens by an extracellular level. It triggers the innate immunity to a faster response. However, it is still on research and development stage, and the assurance is in high response rate.
There are 4 types of non-biological therapies for psoriasis: acitretin, apremilast, cycloproperin, and tofacitinib. They all are oral drugs. Cycloproperin was the first systematic medicine for psoriasis. Some people found cycloproperin helped their psoriasis. Several people found unpleasant side effects when they were taking this drug, like headache, feeling nausea, stomach pains, digestive problems, itchy skin, and difficulty sleeping. Acitretin. It inhibits the introduction of T lymphocyte by suppression interleukin-6 by modulating the gene expression. It also has a side effect like intolerable dry skin, dry lips, and losing their hair. Tofacitinib. It increases the cholesterol level and decreases the hemoglobin and neutrophils. There is another drug, apremilast, one of the most drug in a non-biological are with the minor side effects. Is a medication for the treatment of certain type of psoriasis. It also useful for another immune system related inflammatory diseases. It has very minor side effects like headaches and nausea or tiredness.
Top biological drugs. Ikizumab, a fully human monoclonal antibody of the IgG4 subtype to the interleukin 17A.
Data from a phase 2 study of 142 subjects suggests that is a promising treatment for moderate to severe psoriasis. Over 12 weeks, over 80% of these were treated with the 2 highest doses tested to show reduction in PASI score at least 75%. PASI stands for Psoriasis Area and Severity Index. It's a score used by doctors and nurses to report psoriasis severity. A 100% reduction in PASI scoring was achieved by more than a third of subjects in the two highest dosing groups. Early studies showed reduction in joint pain in those treated subjects also had arthritis, suggesting that inhibiting this arm of the immune system may reduce joint inflammation as well. Adverse effects of the common cold and upper respiratory systems infections were reported.
Bortezomib, fully human IgG2 monoclonal antibody that binds to human interleukin 17A, blocking the activity of interleukin 17 family. Data shows a reduction of 75% or higher and 90% or higher in 12 weeks of treatment, and 77% and 72% of patients. Responders treated with the higher doses of drug tested showed a normalization of epidermal differentiation as determined by a decrease in keratin 16 expression in the upper epidermis, decrease in the epidermis thickening, and a reduction infiltrating CD3 plus cells in the dermis. Adverse effects of upper respiratory infections and mucocutaneous candidiasis were reported.
Thanks for watching our presentation on anti-cytokine therapy and treatment.